Welcome back to the Pager podcast. So this week we are joined by Dr. Alasdair Munro for an episode which delves into all things relating to COVID-19 and children. Dr. Munro is a paediatric registrar and researcher in paediatric infectious diseases at the University Hospital Southampton. And he has been leading the Royal College of Paediatrics and Child Health's review of research surrounding COVID-19 in children for the last year. So he's really the perfect person to talk to about this topic. He's also involved in the Lancet's Commission on COVID-19. This episode was recorded at the beginning of February, and although the pandemic has progressed as ever since then, it seems to have stood the test of time quite well. COVID-19 in children has long been a controversial topic. We talk about why this might be the case, where some of the debate lies, for example surrounding the role of children in transmission of the virus. This brings us back to a common theme running through the podcast in recent months, which is communicating science effectively and how to achieve really nuanced discussions on this topic, particularly online. Lots of our discussion centres around weighing up the competing harms in the form of potential transmission by children, but on the other hand, the harms of educational disruption with school closure and some of the ethical dilemmas faced in making decisions in this area. We move on to discussing why fears of long-term effects of COVID-19 infection in children may be overhyped, and also the parallels between the unknowns of the pandemic and the unknowns that are really intrinsic to the practice of medicine itself and research. As ever, we hope you enjoy the episode. Dr. Munro, it's really kind of you to join me and take some time out of your very busy schedule.
Oh, thank you for having me on. It's a pleasure.
Now, this is perhaps something that you're a little bit sick of by now, but there's been a lot of controversy surrounding children with COVID-19. And I kind of wanted to start off by talking a bit about that, and just by asking what some of the main causes of these controversies have been, in your opinion.
Yes, it has been controversial. I guess that's probably a combination of several things. Like any controversy, it's not always straightforward, I guess, where it's come from. But one of the issues is that wherever there's uncertainty, there's controversy. And there's uncertainty about a number of different things with COVID, but one of those, I guess, is the role of children in transmission. So it's clear now that clinically, children are not hugely affected by COVID. They don't suffer severe disease barely at all compared to most other respiratory infections in children. But what's been more difficult to ascertain is their role in transmission, and that's what everybody's really worried about. And the issue, I guess, is that because children often do suffer such a low symptom burden, it's not always been easy to study their infections and how they have been spread to other people, because it's just been difficult to find children as primary infections to see where it spreads to other people. And there are studies that look at it, but often the methodology is not precise, or there are potential biases that could have influenced the results. So, there's uncertainty there. So there's room for differences of opinion. Now, I think some of the difficulty arises then because when it comes to children, I know, because I'm a paediatrician by training, that emotions run high. That's because people are very understandably attached to their children and to children at large, because they're a vulnerable group in society. And, rightly, we want to protect them. And I suppose that runs in both directions. And obviously, we're in a very difficult situation in this pandemic where we are working with competing harms. And so for children, that means the harms predominantly of interventions used to stop the transmission of COVID, which for them have largely been, prevention of social interactions and, importantly, interruption of schooling, and in some cases, very prolonged school closures. And that's a problem that affects them and harms them mainly for the benefit of other people, which is those who would be harmed by the infection of COVID, when that's not such a big issue for children. Obviously, it's been a huge issue. We've had over 100,000 deaths now in the UK. And so when you have this issue of competing harms, emotions will always run high. And so when you add uncertainty into that mix, you get controversy and you get people with strong opinions. And I think what hasn't helped is some of this has played out on social media, which is an environment that unfortunately works well to amplify polarized opinions. So if you're saying something very extreme, that's likely to be rewarded and amplified because it's likely to make an emotional connection with people. Whereas if you're saying something slightly more balanced or nuanced, people are likely to, they might read it and go, well, yeah, and then scroll past and not give it, the likes or the retweets you might from asserting something in a very strong way. So I think there's been a mix of those things has probably played into it.
You've touched on a lot there. I think my first question really is how, in the big scheme of things, because this isn't something that's unique to the discussion surrounding children and COVID-19, this idea that actually social media and general discussion can often reward extremes of opinion. How do you think we can make these more nuanced opinions more, I guess, interesting, more poignant for people and actually steer their attention towards them and let them have the impact that actually they deserve?
I think that's very difficult, to be honest. I think particularly on social media sites where brevity is king, it's all about short, snappy and attention grabbing, and nuance isn't always. I think we have reached a stage perhaps where people are somewhat tiring of almost chronic, I don't want to say hysteria, but there's only so long you can keep up with such high levels of emotion and it's sort of emotional arousal almost. It's exhausting, and so I do think there's perhaps somewhat more of an appetite now for more balanced and considered thoughts. But again, those are often more easy to communicate on podcasts, for example, or longer blog sites, and you'll never get quite the reach from more long-form styles of communication. So I think it's a real challenge, and this isn't new. This is the same problem they have with mainstream media. I think often attention-grabbing headlines and stories that are perhaps are deliberately made to grab attention and to foster emotions because that's what sells, that's what gets attention. And whereas with mainstream media, that was often it's for money. Often we're now buying the currency is now attention and it's clicks, and I think that is I think it's a difficult thing to combat. I think really people trying to embrace a sense of personal responsibility for the way they're communicating, the style of communication, and for what that's fostering and what type of atmosphere that engenders. So I think that could go a long way. Never before has such a spotlight been shone on the scientific and academic community in public as it has during COVID, and I think it's come as a bit of a shock, and perhaps some weren't prepared, and I think others have grabbed opportunity with two hands to get that attention. Perhaps at the expense of what would have been more beneficial communications for public health.
And on the topic of brevity, do you think to some extent actually, if you are having nuanced discussions around these things, fighting fire with fire isn't really the right term, but I'll use it. Actually, you do need to cut out some of the nuance, because otherwise these arguments and these balanced approaches simply won't be competitive with what is dragging people's attention away. And I know that might seem painful as a scientist and as a doctor, but to what extent do you think it's necessary?
I think it's possible to convey nuance and balance with brevity, but it's just much more difficult because you only have so many characters, and you need to think much more carefully about how you choose your words, and you sometimes have to say less and make what you say more true and more careful. So rather than just saying oh, X is obvious, why aren't we doing this? It's been obvious for weeks. You just need to think a little bit more carefully about, well, if I feel like that's obvious, why hasn't it been embraced? What have been the barriers to that? Is that something that I can address? How can I do that accurately in as few words as possible? I think that, and this is something that I know that speaking as a non-expert here, but journalists, really excellent journalists, often prize brevity, I think, and saying, it is a skill to be able to say something complicated and something, difficult in as few words as possible. And I guess that it just needs more effort. I just think, and I think it's worth putting in for people to just think a bit more carefully about what they're saying, to try and make it more careful, more considered, less inflammatory, less polarizing, because it can still be good and it can still be worthwhile. And I guess trying to if you're utilizing social media, trying to make your goal being amplified for the quality of your content, not for the excitability.
I had a great phrase, I think first in The Economist, which said journalism, or high quality journalism, is like diamonds, better when cut.
Yes, The Economist actually was exactly what I was thinking of when I made that statement. It's where I've read some excellent quotes on that topic. So yes, absolutely.
I'm aware of time, so I'd like to kind of change tack slightly and touch upon something you mentioned earlier, just about these competing harms. And really to simplify it down, we have the harms, obviously, of spread of COVID, and of which we know children play a part, but to the extent to which they play a part has often been misrepresented, I feel. And then also we have the harms of restrictions on children's development, their education, etc. How do we balance out, in this case, the consequences which seem to have very different units, in a way? Quantifying kind of COVID transmission is perhaps something we can do in the short term, but actually quantifying long-term educational impacts seems very different, and seems, how do we say one is equivalent to the other, which is ultimately what we must do in this calculation? That's what we must try and do, absolutely. And it's a really important question, and I guess one of the things that some of us have struggled with is this idea that you can be following the science in that sense, because ultimately when you come down to some harms that are impossible to really quantify, I think you're really making an ethical or a moral decision rather than a scientific one. If you were, for example, focusing just on years of life lost, that is that would be an approach you could look at, but that would be so extraordinarily difficult to try and quantify with a degree of certainty that it would be worth doing, that it almost becomes not worth doing. Those are the kind of things we have to think about. But it comes down to more than just years of life lost, because it's quality of life and it's long-term harms that, as you say, are uncertain, because we've never inflicted this sort of intervention on a generation before, and in global terms the impact is enormous. And there are some things we can count. We can count the number of days of education lost. We can count the number of children whose vaccines have been postponed or delayed in different countries. But ultimately, what that all adds up to in terms of human health, how do you put a number on that? How do you quantify it? And then you think about the effects on children's mental health acutely, and then think about what the possible impacts of that are in the future. I don't know how you can put a number on it. And so ultimately, when it's incalculable, you're really trying to make value-based decisions almost. What is it that we value more? And it's a really difficult discussion to try and have, because whichever way you turn, you're either allowing or inflicting, direct or indirect harms on members of society. And I think we've got a bit lost on thinking that it's just we can just solve it by science. If we just do better studies, we can solve it. More data is helpful to try and get better estimates on the impacts of things like, if schools are open, how does that influence transmission? But ultimately, it will never answer the question for us: should we close schools to prevent transmission of disease? Should we
harm children to predominantly save the lives of elderly people? Some would say absolutely yes, and that's completely valid. I know other people who would say absolutely not, and really, I don't think there's an obvious right or wrong answer, which is why it's a very tricky problem.
And one other question that's come out of this is where the burden of proof lies for these interventions, particularly given that the intervention in this case is a change from the status quo. It's a change from kind of open education and children going about their lives as normal. Because ultimately, a decision has to be made regardless of whether we are in a position to make a completely evidence-based decision in the first place. That doesn't take away from it.
Yeah, absolutely. And I think there's two different scenarios there. So I think when you have almost no idea at all, then I think you make an acute risk-benefit calculation. So, for example, at the very start of the pandemic, when it was really unclear exactly how fast it was spreading, how many people were infected, or how many people would die, a plan to close schools acutely was justifiable because the potential risk of keeping them open, could have been catastrophic for all we knew. Really, apocalyptic. And whereas the harms of closing them, we know what the harms would be of closing them in the short term. The potential risks, could be justified by closing, because we really didn't know. What becomes much more difficult then is as time goes on and we've better been able to quantify the transmission of the virus more broadly and the likelihood of hospitalization and death, that then the calculus has changed, because we're not operating in the dark anymore, and then we need to try and make some trade-offs, and then the idea that we're operating in an emergency has changed. And I think that's where we find ourselves now, and that's where it's difficult. And obviously there is a difference of opinion there. And some people, I think, have been utilising what's known as the precautionary principle to say, well, if we don't know if opening them is harmful, then we should take the whatever the most cautious measure is and keep them closed. But that ignores the direct harms of closure, because you're not talking about better safe than sorry, because closing schools inflicts harms. So you're really talking about competing harms. The precautionary principle doesn't really apply for something which is directly harmful. The argument for masks, for example, was often made on the precautionary principle, which is fair enough, because for the vast majority of people, wearing a mask would be of really negligible harm to them, whereas the potential benefits would seem to easily outweigh that, almost always. Whereas it is not the same for school closure. You're talking about inflicting direct and indirect harms on millions of people, and so that makes the weighing up of the risks different. And obviously it changes based on the situation, that as it has done. I think our government has been right to prioritize them as the last to close and first to open, but given the situation over Christmas and everything, they felt that the balance had tipped. And I think it's fair. No one knows when the right time is, but we know that the situation can change, and as such the balance of risks and benefits changes too.
And I'll focus in on one component of this calculation, because I think it'd be slightly harsh to grill you on the long-term effects of kind of school closure, which I think everybody is uncertain on. But one thing that you've certainly done a lot of research into and a lot of synthesis of the evidence around is looking at the contribution of children to transmission. Could you tell me about some of the challenges that you faced here?
Yeah, okay. It's been a difficult topic to research, because the more general a question you ask of it, the more messy the data becomes and the more uncertainty. So, you can sort of take a close look at children's susceptibility and infectiousness, and we've got a reasonable indication that younger children may be less susceptible to acquiring infection than adults. How infectious they are once infected has been more difficult to ascertain. but we know they're certainly infectious, and probably asymptomatic people now, we've got a good indication that they are less infectious per exposure than someone who is symptomatic or will later become symptomatic. So we've got good reason to believe that an individual child is less susceptible, and probably children as a cohort are somewhat less infectious because they are more often asymptomatic. So what's more difficult is then when you say, well, what happens in schools? Because the studies are imperfect. We don't have any really good evidence that schools are huge hotspots of infection. That's been really difficult to find under most circumstances. But a lot of studies have been done on the basis of symptom-based testing, which, as we've discussed, if children are asymptomatic, we may not always pick up all of the cases. And then if you go even wider and try and look at school reopening's effect on communities, that is extraordinarily difficult to study with any degree of certainty, because you're talking about things that are really so closely interconnected that being able to tease them all apart is almost impossible, particularly because things like school closures as interventions were enacted often within several days of lots of other policy changes and these types of things. So that's been really hard to get a gauge on. And I think people feel very passionately about different types of strategies for controlling the disease more widely, and I think different people have different feelings about whether any transmission at all is acceptable, or whether we should be aiming for absolutely no disease anywhere. And I think that very much informs the way people view some of this evidence. So where if there's any uncertainty and your philosophy is that we should be aiming for no transmission of COVID at all, then obviously in your mind, schools are an issue, because we will see transmission within schools, and that is therefore unacceptable. Whereas people who feel that we are going to have to accept some level of transmission for the foreseeable future, seeing low levels of transmission in settings of low to moderate prevalence probably seems more acceptable. And I guess some of the controversy and acrimony sometimes comes from the fact that people have strong emotional ties to their philosophies on the control of the virus more broadly. I imagine.
I think it's worth pointing out that actually we are accepting a decent level of transmission anyway, even during lockdown. When you look at the curves of the virus falling from kind of the peaks in early January, were we to have an R value of 0 or 0.4, we'd see a much sharper decline. So there is transmission going on in other settings, which seems to be permissible. And I think it's probably, from my perspective, I guess my philosophy on it is that actually you need to be applying a kind of a fair approach across all settings of transmission in order to kind of make a decision about it. Clamping down on one where actually the consequences of clamping down can be argued are very great doesn't seem fair in the context of not clamping down on other ones.
Yeah, and I think we're lucky, at least in the UK, that we're probably in a better situation than many other countries. So, for example, in lots of areas of the US, schools are closed, but restaurants and casinos are open. And I mean, that to me, that's staggering, absolutely staggering. And in some other European countries, they're not enforcing people to work from home, but schools are closed. And when you look at the harms of those interventions, that seems a strange decision to make. But yeah, I mean, you bring up ongoing transmission. I think one of the other problems that's been overlooked here is the social determinants of disease. We've known for countless years that communicable diseases are diseases of the underprivileged, and that has remained the same for this pandemic as well. And people who are essential workers, who are the ones, while people like me, sit in my home office all day typing away and doing my job, who are out, collecting bins or delivering food or parcels or working in warehouses, are still exposing themselves and are still suffering, the consequences of transmission. And people who can't afford to take time off work to self-isolate, are struggling to make ends meet. And if they get a little ping on their NHS app saying you've got to, keep yourself in your room for 14 days, and they're not going to be able to pick up their 0 hours contract, well, there's not a strong incentive there for them to necessarily comply. And I think these have been, these are wider societal issues that have not been adequately addressed. And I think it's a shame that we've had to resort to things such as closing, primary schools and trying to ask 7-year-olds to learn via Zoom screens when we still have a situation like that ongoing.
It brings up the idea that on one hand, the government's kind of push to put things on the individual has been a positive one in that it's encouraged kind of responsibility for certain actions, but on the other hand, it's put people in an incredibly difficult situation and almost abdicated any responsibility to allow people to make good decisions around it, whether it's about self-isolating, following symptoms, whereas actually some people are in a brilliant position to do that and some people are in a horrific position where most reasonable people wouldn't be able to follow those rules.
Yeah, absolutely. And the problem is that you're relying on a social contract if you're going to say something like that. So if you're going to, you sort of are, you're giving really competing messages when you're imposing large fines and putting statutes into law, but then also putting, the individual responsibility, responsibility on individuals. You're not engaging them with the public and saying, we need a mutual contract of trust where you trust us to try and run this, and we trust you to do the things necessary to bring transmission under control. It's simultaneously saying, you must do these things, but we don't trust you to do them. And then likewise, you have lost the trust, the state has lost the trust of the public in that sense. And there's been some very notable incidences which I think, perhaps haven't helped the government in that way to garner trust from the public at large. But I think sort of saying to people, we need you to do this and we trust you to do it, but we're not going to help you by enabling you to live whilst you're self-isolating has been a bit self-defeating. Threatening to punish people for doing things that it would be extraordinarily difficult for them to do. Again, it doesn't help foster that social contract, that cohesion, and that mutual trust that you need from the state and the public to try and move forwards.
And I'd like to, I think it's a really interesting topic, but I would like to steer away slightly for now and just move back to some of these questions around transmission. And I know something you've talked about before has been this shared exposure bias in terms of looking at particularly how infectious, how often children pass on the infection. Could you tell me a bit about that?
Yes, sure. So this was something that came up in a study that was published from South Korea initially. So they have a really fantastic contact tracing team there and data collection. And over the summer, a paper was published that made the front page of the New York Times and lots of other things, saying that children aged 10 to 19 were as or more infectious than adults. There were wide confidence intervals, but this headline was sort of drawn on to make inferences about then whether schools could open and what this meant. And it was very controversial at the time. Now, what had actually happened was a different team in South Korea had looked at exactly the same data and had looked at how many infections had resulted from children who were identified as index cases. But what they did was, of all of the contacts they found who were infected, they looked for how many of those had actually been with the child when the child had been exposed to the infection initially. So the child and their infected contact had both had a shared exposure initially. So and of the 41 contacts who had become infected, 40 of them had shared that initial exposure with the child. So what that means is if you hadn't looked for that, you would find the child was infected, test their contact and find they were infected and say, okay, well, we assume then that the child infected that contact. Whereas in reality, you don't know whether the child infected the contact, whether the person who infected the child infected them and that contact, or whether the person who infected the child actually first infected the contact who infected the child, and you've got this strange sort of triangle of infection where you don't know what the direction of travel was. You don't know what the links in the chain were, and there's no way of really teasing that out, particularly for an infection like COVID, where you can have something called a negative serial interval. So a lot of the way we determine who infected who in these types of studies is by symptom chronology. So we assume that whoever had symptoms first was infected first. And a serial interval is the time between one person becoming symptomatic and then they infect someone else, and the time that that person becomes symptomatic. But in COVID, you can even have a negative serial interval where, say, I became infected with the virus and I've not got any symptoms yet, and I come along and I infect you, George, and then a few days later you become symptomatic, and then a few days later I finally develop symptoms. Now, anyone who then came and tested us and checked our symptoms history would say, oh, well, George, you must have infected Ali there because you became symptomatic first. But actually, I just had a much more protracted incubation period before becoming symptomatic, because there's a huge degree of variability there. So that's the other thing that makes it really challenging and adds to the uncertainty of these investigations. And I think it just highlights how difficult it can be to interpret some of this contact tracing data, because there's so many different factors that can influence how you come to some of the numbers at the end, and how much those can change, based on a few different parameters. It's been easier for determining children's susceptibility because there's fewer biases that can influence people testing negative. So if you don't find infections in people, that's more straightforward than when you find lots of infections. Because when you have lots of infected people, knowing who infected whom and when and how is more difficult. Whereas if you've tested someone and they test negative, there's only a handful of reasons why that could be the case, and they tend to not have such a big influence on the results.
Another, I guess, point that's been brought up, and I think very broadly within this, and I think something that is important in research in general, relates to long-term consequences. We're quite good at measuring short-term consequences, looking at mortality in that setting, but one of the criticisms that people will put on relaxation of rules, or, for example, introduction of a new medical intervention or therapy, is that we simply just don't know the long-term consequences of it, and therefore, better safe than sorry. We should avoid the exposure in the first place. How can we approach this sort of question, which seems to undermine evidence-based medicine in a way, because you can't really say for sure that there aren't going to be long-term consequences without waiting?
Yeah, exactly. So I think, again, this comes back into weighing up risks and benefits of different types of actions. And I think it also goes in a little bit into sort of a Bayesian type of thinking. So, it is true to say that we do not know for certain what the long-term consequences of asymptomatic infection of COVID in a given child will be, because the virus has only been around for a year, and it hasn't even been around long enough to, that even if we were studying it in great detail, we wouldn't know by now. So it is true to say that we cannot know for sure. Now, does that mean that we don't know anything at all? No, it doesn't, because we do know some things about respiratory infections in children. We know some things about asymptomatic infections in children and in people more generally, and we know some things about COVID. So although we can't say we can be 100% sure, we can make some reasonable guesses about what is likely to be the case, on the basis of our experience with other respiratory viruses and similar types. And I think that's where we have to approach it from. Because what we're talking about here, as I said before, is a balance of risks and benefits. So we can try and guess what the risks of an asymptomatic infection in a child are of having serious long-term health consequences. And the reality is that our best guess would be the risks of that are extremely low, because there are very few examples of acute respiratory virus infections in children that would go clinically unnoticed, that would later on have serious health implications for most children. That doesn't really exist. There will be, there are some examples of, latent viral infections that could potentially have extremely rare and serious consequences, but nothing where we would expect that to be of serious detriment to most children. So we can make a reasonable prediction on the basis of past experience, and on the basis that we know we know at least hundreds of thousands, if not millions of children have been infected with COVID-19 so far. And our hospitals and GPs are not yet overrun with stories of prolific long-term consequences. We do have reports that there are children who seem to be suffering from post-acute COVID syndrome similar to adults. They're often called long COVID, which from the experience of most of my colleagues looks very similar to a lot of other post-viral sort of chronic type symptoms, fatigue and brain fog and this type of thing in the most part. And I'm sure we will see some weird and wonderful consequences, because millions of children have been infected, and viruses do weird things. Viruses are weird. But yes, I think you're right that saying we don't know, therefore the safest thing is to just make sure none of them get infected, it's not a sensible solution, because again, we're talking about competing harms. And whilst we do not know, we can make some reasonable predictions about what we think the likely harms of asymptomatic acute infections will be in children. But that is competing against the harms of what it will take to prevent those children from becoming infected at all, which are absolutely enormous for many children at an individual level, and certainly for wider society at a systemic level. And particularly in terms of equity, in terms of having an equitable society, because we know that those harms fall predominantly on the children who are already most disadvantaged in society. And I don't think that that's the kind of society that we want to be. So yeah, competing harms and trying to make reasonable predictions based on existing knowledge, I think is the way to try and make those decisions.
And almost play devil's advocate, how would you respond to somebody who turned up, for example, and spoke to you and said, okay, I accept what you're saying, but this virus has bucked a lot of trends before. Back in January last year, we thought that that asymptomatic transmission was something that just wasn't going to happen. We've seen some cases in children of quite severe kind of inflammatory responses, albeit very rare. If we couldn't predict these things before, then how can we predict these things in the future with the certainty that some people are predicting them?
I guess we can't do it with certainty. That's the truth, is we can only make reasonable suggestions or reasonable predictions. And people, I think, SARS-CoV-2 has, I think, gained a reputation, perhaps somewhat unfairly, of being a particularly weird virus. I've got to say that compared to many other viruses, it isn't particularly strange. And I don't think it's really done anything that we've not seen in any other virus before. So there's plenty of other viruses that have asymptomatic and pre-symptomatic transmission. There's plenty of other viruses that cause inflammatory responses, or can cause lung fibrosis, or can cause blood vessel inflammation in varying degrees. It's its own virus, so it has its own constellation of things, but I don't think there's anything that it's done that has been completely unique. I suppose the closest thing is possibly the hyperinflammatory syndrome in children. However, we've that type of syndrome is not unique. We've seen that type of condition in Kawasaki's disease and in HLH, and we do see children with hyperinflammatory syndromes with no obvious etiology that we assume is caused by viruses, because viruses get blamed for everything we can't explain in children. So I don't think it's too weird. We could never rule out. We can't rule out any possibilities.
I think it's a really good point. That actually, I guess, first of all, if you multiply a probability by a million or 10 million people infected, then you're bound to find strange things, and you're bound to find also a lot of things that actually had nothing to do with the virus in the first place. So basing your decision making on anecdotes within that can be quite dangerous. And secondly, as you said, there is no precedent for the sorts of long-term common kind of detrimental effects on child development of the virus and viral infection itself, whereas I'm sure we can find precedents for damage to children's well-being and development from loss of social contacts and education. My mind is put at rest.
I'm so pleased. I'm so pleased I could be a nice calming influence.
I think we also probably perhaps see this in any trials, or any clinical trials involving children, and perhaps the same arguments are true there. There's no precedent that a new antibiotic used in children is going to cause certain effects beyond what is a reasonable follow-up period in a trial, which is, I guess, the reason why we can define what is a reasonable follow-up period for different interventions. And for some of them, for, say, an implant, that might be far longer than for a short round of antiviral therapies. It's intervention dependent.
Yeah, absolutely. And again, you cannot know that before trialing a medicine, but you have to just go on the best available evidence you have, given the track record of that type of pharmaceutical, the evidence you've gained from animal models and from preclinical studies, and then you just have to make a decision that, well, it seems safe given what we know. It will benefit people to have this medication. Therefore, on balance of risks and benefits, the most beneficial thing is to put this medicine into human beings and to trial it and see what happens. And this is, we take risks like this in medicine, I guess, all the time. If you think about chemotherapies, we're doing something knowingly harmful because we believe in those instances that the harms of those toxic medicines is outweighed by the potential therapeutic benefit. And will that be the case for all people you give the chemotherapy to? Absolutely not. But you don't know which ones it will and won't, and you make those decisions on the basis of probabilities. And it's an uncomfortable position. It's not a direct comparison to what we're having to do with wider society, but it's there are some parallels.
Perhaps making a tenuous link, I guess one of the things that is so crucial when discussing your example here of determining which chemotherapy agents a patient would like is actually taking into account their personal preferences and what matters to them and how they see the potential risks and benefits in making a decision. Things get a little bit murkier when we start looking at children. And one of my questions is, particularly as a paediatrician, how do you almost approach this boundary between what is a reasonable decision for a parent to make for their child and what is a less reasonable decision? And it seems like there's a grey zone within the middle where we think, does parental responsibility and do parental rights cover this or not, on the basis of what are their personal preferences? I was wondering if you could talk a bit about that.
Well, that's a very that's a very difficult question. And again, it's an ethical question, and it's not. There's no single answer because it really it depends on the child and the child's age and the child's capacity, and it depends on what it is that the decision is being made about. So that's it's a very case dependent. I think the bigger problem that we have here is that we are talking about making decisions on behalf of children that are not necessarily in their interest, but it's in the interest of others directly. So I think that's an even more difficult ethical area. It's like giving chemotherapy to someone else in order to help a different person, if you see what I mean. It's giving a toxic medication to a different person, and how do you balance that up, and who gets to make the decisions about that? And I guess that's where we're sort of trusting our national institutions to make those decisions based on a population health level. What maximizes or minimizes overall harms to health of the population. So it doesn't really come down too much to individual decision making, although I guess there'll be instances, for example, where parents will feel that for whatever reason, whatever is best for children as a whole in society is perhaps not best for their individual child. And I'm sure there are probably circumstances where that is the case. But yeah, that's a difficult scenario.
I'm imagining a parent who had, I guess, a different perspective on the risks of COVID transmission and what should be done to curtail it, and in the end ended up potentially detrimentally affecting their child's education, and where their almost rights would lie in this category.
Yeah, it's difficult, isn't it? Because I guess again, that's probably situation dependent. I know homeschooling has apparently increased quite a lot during the pandemic, and I would imagine probably for most children in more privileged homes, that's probably not going to be of huge detriment to them if their parents have the capacity and the resources to be able to do that well. Then for that individual child, that probably isn't going to be a big issue. I guess what the concerns are that, for example, if you allow it fully to a parent's discretion whether to allow their child to attend, that we will see what we saw back in spring, and I'm not sure to what extent it's happening now, but it's whereby even where vulnerable children are allowed to attend school, that they don't, because it is not mandated, and therefore children from perhaps difficult backgrounds are not being encouraged to attend, or are not being brought because it's easier not to. It's easier to slip through the net. So I guess that's where there's a difficult decision about if you leave it entirely up to people's discretion, then the children who probably most need to be there or who most suffer from not attending may be the ones who are least likely to attend in those circumstances. So that is difficult.
As ever, no easy answers to questions like this, but worth thinking about still. I think that's probably a good point to end on for today then, because I know you've got lots of other things to get on with besides chatting on this podcast. So it's been so kind of you to take the time away from your work and from your children in the background as well.
Yes, thanks, John. No, it's been a pleasure. Yeah, far-reaching, very philosophical discussion. I enjoyed it. Thank you.
Indeed, yeah, bits of everything. So hopefully everyone enjoys it.
Great, thanks, George.
Thanks for listening to the Pager podcast. If you've enjoyed it, do leave us a review, share it with a friend, and come back to listen to our other episodes. As ever, we'd love to hear what you think. You can reach us at Pager Podcast on Instagram and Twitter, or email us at pagerpodcast@gmail.com. Bye for now.